should have you doing a song and dance show or something to entertain people while we're waiting for everybody to come in.
Oh, I could do something, I'm sure.
I'm sure you could.
I'll sing a song.
There you go. I'm not sure which one might be appropriate, but
No.
we've still got a few more coming in. Well, just another couple of minutes.
I'll be back soon.
I probably caught people at the end of a
Paerewa Country Lodge here.
much needed lunch break. Hi, Daryl. Hi there. How are you going?
Good, thanks.
Hi, Daryl.
How are you, Mark?
I'm good. How are you?
Yeah, all right. We've got a few residents testing positive and a number of staff off, but we're getting through it currently.
Oh,
Yeah.
Well
It's
done.
second wave.
You haven't got that on your own by any means, unfortunately.
Yeah, no.
We didn't mind if you will send someone to help us.
Oh, I wish I had somebody up my sleeve to come and help you all.
Okay. Maybe you can clone yourself, Gillian. We need a registered nurse. They
A
know the
registered
care
nurse,
plan.
you might not want to clone me. That might not be good.
Hi, Gillian. How are you?
Hi, good. Thank you, Rachel. Yourself?
Yeah, good, thanks. It's a good day. The sun's out.
Absolutely. I know it's nice to actually see some blue, a hint of blue sky.
Right, I'm just
Hi,
going to go
Gillian.
upstairs, but then I'll be back.
Okie dokie. Hi, Harry. How are you?
I'm good, thanks. How are you?
Good, good.
Yes. It's a busy time of the year for everyone.
Oh, it's a very busy, crazy, busy time.
Yes,
Everybody's
now-
under a huge amount of pressure.
that's correct. And now the second booster dose is rolling out. So yeah, so I think we are getting organized for a clinic
Very
for
good.
residents and the staff.
Ah.
Yeah.
So yes, you'll all be going through very similar things at different times, as depending on where in the country you are.
Yeah.
So today's session is predominantly focused for HCSL clients, but of course we do have a few other people joining us as well, which is absolutely fine. The more the merrier.
Yes.
So we've still got people coming in. What's the time? 2:02. We've got some people joining us via their phones. So once again, just a reminder, as you're entering, if you can mute your microphone, please. And keep an eye on the chat box as we go through the session. I'll go through the session and we'll give the opportunity for questions and answers at the end, or hopefully answers as well to your questions. But we will do that at the end of the session. So as we go through, if there are things that come to mind, note them in the chat box and then we can address those at the end. Or you may want to hold on to your queries and send us an email afterwards. All right. So Mark's going to keep an eye on the chat box for us today. So you'll be able to see Mark's got his camera off at the moment. He's hiding, probably having a last bite of his lunch. Are you there, Mark?
I was waving from Caroline's desk.
Right, and of course I can only see a few of you, a very small number of you, so I'm not ignoring the rest of you if I haven't said hello. So Mark is going to keep an eye on the chat box, and if you write your questions in there, as I say. So let's get underway. For those of you that haven't met me yet, my name is Gillian Robinson. I'm the founder of HCSL, Registered Nurse and Auditor, and have been working in the sector for a very long time, so I've seen lots of changes like a number of you have. And the changes that we're talking about today relate to the new Paerewa Health and Disability Services Standard. It's a combined standard, and we're going to focus predominantly on the restraint section of those standards. But just as a refresher, I'm just going to go through and just talk about the context, and we'll start through the session and talk about the basis of some of those changes as well. So firstly, I just need to hit the right button. There we go. Okay, so as I said, these are a combined standard. They reflect not only aged care services, but community, home and community support, fertility services, abortion services, and a wide range of different services. And what we know about healthcare is that it's not one size fits all. One size definitely doesn't fit all. So context does matter. And each time I go off to let somebody else into the system, it is throwing my presentation out. So as I say, one size doesn't fit all. We started back in 2008 or 2004 with the original standards, and then 2008 they changed, and then we've had some updates, and now of course we have the Paerewa Health and Disability Services Standard 2021. That was implemented from the 28th of February this year, so it's at the early phases of implementation. The audit agencies will be auditing against these new standards from the 28th of February this year. So any of you that are due for audits will be having those audits happening now. Some of you may have had a postponement of audit or a delay because of COVID. And if you're due for a surveillance audit, normally in the past you wouldn't have been given prior warning of a pending audit. Normally the audits are unannounced. So with COVID and outbreaks, of course, that changes things. You can't have the auditors come on site if there is an outbreak pending, or you don't know if it's pending, but if it's happening at the time. So in that situation, they will contact you, and you may have the option of deferring that. If you are having extreme shortages with your staffing and you're not able to proceed with an audit, then I suggest that you contact the audit agency and let them know. If you know that you're in that period where you are expecting an audit, let them know, have that communication with them. So as I mentioned, there are grace periods. There are a number of new criteria. There are 20 partially new and 27 new criteria in this new standard. Now, some of those don't relate to aged care services. So that's the full sort of picture of what's happening with the standards. You have a 6 to 12 month grace period for partially new, and a 12 to 18 month grace period for those criteria that are completely new. Now that means that although you get audited against them, if there is a finding, there will be a recommendation and just an alert given to you to let you know that there's still some more work to be done for full compliance to the new standards. But because you've got that grace period, there won't be a corrective action against that particular finding or recommendation. All right. So hopefully this will continue moving forward. No, it's not. Okay. So one of the changes that has come through, and it's a result of the Heather Simpson report in 2019, where it was acknowledged that there was inequity in services and inequity in the system. And that was backed up by the lack of evidence and lack of data to verify equity. So I remember going around the country talking to a number of you, a number of others that work in the sector and health colleagues, and I'm saying, well, hang on, why should people be treated any differently? Everybody should get the same services. And I understand the concept of what they're talking about, but that actually doesn't work. So if we go back to the treaty, the Te Tiriti o Waitangi, the principles within the Te Tiriti are incorporated throughout the standards. So I said we would predominantly be talking about restraint today, and we will, but I want you just to sort of reflect for a moment on the Te Tiriti principles are incorporated through all of these criteria, not just those that relate to cultural safety or cultural awareness. They are the background concepts behind everything we do. All right, also thinking about the Olamanua Pacific Peoples Wellbeing Action Plan. The Whakamoa Action Plan is the Maori version of this, and thinking about recognizing those two groups of people in particular, and thinking about equity. Now, the one size fits all doesn't work for equity, and I'll show you why. If you have a look at this picture here, we can see the difference between equity and equality. I think sometimes we have the term equality in mind when we're thinking about equity, but they're not the same thing. As you can see, we can give everybody the same thing, but they're not going to get the same outcome. And we want everybody to get those best possible health outcomes. That's why we have to adjust and think about the different groups of people and the different individual needs. So here's another diagram that explains that again, the difference between equality, giving everybody the same bike, despite how big they are, how small they are, what their mobility is, isn't going to give them the same opportunity to take that journey. Whereas equity is looking at the individual and matching the services to their needs. So that's just sort of setting the background of some of the concepts. Equity is certainly a very clear concept in the background of these new standards that's highlighted more so than was the case previously. So the sector guidance, there is sector guidance. If you put in a search engine and you go online into Google or whatever search engine you're using and put 8134, referring to the standards, just put 8134 and then sector guidance, it will take you to the guidance that the Ministry of Health have put together with the Health Cert team to help implement and give you some suggestions of how you might implement those. For those of you that are HCSL clients, you know that we are doing this work for you. We've gone through and worked through the policy and procedure updates, and they are being supplied as you come due for your next review of policies and procedures. That will happen automatically. So we'll have sessions like this just to help you understand some of that a little bit more. We've also got some interviews that we are releasing, I think, next week or over the next couple of weeks. You'll receive a MailChimp newsletter type format from Mark that will send you through a link to video interviews, and those are with the Reverend Neti Pataya and Philomena Pataya, his daughter. The Reverend and his daughter, she's a registered nurse that works in the Samoan Trust or Samoan Health community, and some really, really interesting insights in relation to aged care services. Both of them have had an intimate involvement with aged care services. So I think you'll find those really, really helpful, as well as looking at that, as I say, the sector guidance and reading those new policies as we send them through. Now, we've highlighted on the indexes the documents that have changed since the previous version, but please look at the whole document. Don't just look for a paragraph that might be different. Look at the whole document so you're getting it in context. So what is it that we want to know about in relation to the, I'm just going to move the books out of the way here. What is it that we want to know in relation to these standards? We want to make sure that these restraint standards are implemented, or the restraint standard part of these new standards, because it's all incorporated. We used to have separate ones. It's not, it's all incorporated. We want to have a look at the components. So I'm just looking at the key components here to start with, and then I will break down those partially new and the new criteria. For everything else, it should be, for want of a different term, business as usual. You should be doing those things that you've done in the past to comply with those other criteria. Adding the cultural aspect, thinking about cultural assessment and advocacy and consultation a little bit more into each of these concepts. So thinking about governance commitment, that's the one of these new areas that we will be looking at more so, and I'll talk about that a little bit more in a minute. Leadership, once again, you've had your restraint coordinators before. The terminology might be slightly different in this new standard, but that's the term that it's looking for with that executive leadership role. Advocacy, yes, we want to make sure that we have people having support and recognizing that support for me as non-Maori or non-Pacific might be one person, but advocacy and whānau consultation for Maori or Pacific people may be a busload of people. So think about that. What's the context and how does it change? How are you going to accommodate that advocacy and that consultation and that involvement? So those usual processes of approval, assessment, cultural assessment as part of that development of your care planning process, thinking about trauma-informed principles. And if I'm talking about some concepts here that you haven't come across before, please send me a message and I can go over those or send you some more reference material to those. The new policies and procedures have got a number of digital links in them that you can click on that will take you through to extra reading material, extra reference material that will give a broader context to this as well. And of course, monitoring of restraints when they are in use, and debrief review, the internal audit process to look at how you actually doing things. Are you following your policies and procedures? Are you following the concepts of monitoring in accordance with the frequency that's noted in the care plans? Those things that you're used to doing. So if I move on here, sorry. Enablers, another change. Enablers are not part of the standard. Enabler is a concept that was used in the previous standard, which actually restricted mobility. It didn't enable, when you think about a definition of the word enabler in accordance with the standard dictionary. So it's been taken out. It did cause a lot of confusion. I'm pleased to see it's been taken out. So one of those things that I want you to do, whether you're an HCSL client or not, is to look at your restraint register, restraint and enablers that you may still have noted as enablers, and review them and think, is it a restraint or is it a mobility aid? Is it a safety device? Is it something else? Look at the definition of restraint in your policies and procedures, read those policies and procedures as they come through, and that will be very clear to you. If it's not, please, as I say, communicate with us and let us know. So determine which are still, reclassify them, and make sure that you haven't just reclassified them within the restraint log and restraint care planning process, but in the long-term care plan, so that that information all correlates there together. You will get automated in the HCSL system, once again, automated reminder notifications of when the restraint reviews are due. Those are based on the dates that you're putting into the system. If you aren't getting those, please let us know. If there are email addresses that need those notifications to go through that aren't happening at the moment, please once again contact at support@agedcarecompliance.com, and we'll get that teed up for you so that you are getting those reminders. Now, as I said, let's dig and delve a little bit more into the partially new and the new criteria in this particular section of the standard. So it's section 6 that we're referring to, and seclusion, I'll address that to start with, is not applicable in relation to age residential care. It's not something we do, not something that we would look to do in age residential care. So we are focusing on restraint. So the first of the partially new criteria is 6.1.1, and it's talking about governance bodies. Governance bodies' commitment not to minimisation as per the previous standards, but elimination. What we're aiming for is eliminating the use, completely eliminating the use of restraint. And some of you might be scratching your head thinking, but we can't do that. People are going to be unsafe if we do that. Once again, go back, read the sector guidance, read your policies and procedures, look at your assessment process. Have you tried every possible other alternative? Are you using the least restrictive? Are you trialing other things? Who have you consulted? Think about those external people, your allied health people that might be involved, your physiotherapists, your psych services personnel as well. So there are a range of people that you can consult. And of course, talking to the resident, talking to their family whānau, and saying, what situation have they been in before where they may have been at risk? What were the remedies? What were the strategies that were put in place? So thinking about that, governance bodies elimination strategy must be noted in your organisational objectives and measured. So reviewed to see how we're getting on. That means that you as a team, whoever is reporting to governance, needs to make sure in the minutes of your meetings or your reports that you submit that that information is going through to governance so that they understand what's actually happening and where you are at on that measure of trying to eliminate the use of restraint. So also thinking about the next one, which is partially new, 6.1.3, that executive leader. Once again, as I said, that was somebody that we would have thought of in the past as the restraint coordinator. And once again, the key here is the word, not so much minimisation as the previous standards, but now elimination. So it's the same concept that we're looking for in 6.1.3. So those two levels of management and the approval process, the review process, that reporting process, that measuring process, how are you doing that? What are your internal audits showing? On to the next one, 6.1.4. These are new criteria, these two. So 6.1.4 is reporting restraint. Once again, that restraint coordinator or executive leaders report, identifying the intervals, talking about data, what is it that's being reported, thinking about the type, the frequency, how often are you reporting through to governance? What's happening in relation to de-escalation? Are your de-escalation strategies effective or are they not effective? How often are you changing them, or are you just doing something because that's what you've done? Making sure that you've got that reflective practice. Who do you need to involve once again in that conversation? So also then on to looking at 6.2.6, which is the other one of the new criteria, safe restraint, when it's determined that there is no other option but to use restraint, shall consider the most appropriate member of the workforce to debrief the person. Now, remember that the auditors need to look at this in the context of your service. Also thinking that this was written with a whole lot of different services in mind. So every service that's providing a health and disability service, a care service to a person, is going to have to comply with this, and the context in which they do that will mean that the strategies developed will be a little bit different. Now, interestingly, when I went and had a look at the sector guidance to see what was suggested as a strategy to meet this, this is what I saw. Guidance has not been developed for this criteria. So if I go back again, have a think about how the monitoring of restraints is being done. And when we think about safe restraints, where is the risk? How is the risk around use of restraint being managed? Is it being identified? Is it being managed? Is it being mitigated? Think about risk, because the key word here is safe restraint, I think, as far as the aged care, aged residential care services go. So interpretation may vary. You know, we're all on a learning curve. That's why we're here having this conversation today. We're all on a learning curve. That includes the auditors. Some auditors are new, some of them haven't audited against the previous standards, so they won't have that frame of reference. Some of them will have. So once again, things will be a little bit different. If you have an audit and the auditor suggests or makes a recommendation or a finding against a criteria that hasn't come up before, that is new to you, and you think, oh, well, that isn't actually a new criteria, why has that been said? Query them and contact us. If you're an HCSL client, please contact us so I can communicate with the auditors, so I can try and understand what it is that they've seen that's made them think that there is a compliance deficit there, and we can communicate with them and have that conversation. We do work very closely with the audit agencies, and we have had some communication definitely with them very recently. And I've got a couple of examples here. Think about the words. You know, go back to the old school exams. We all had exams, and sometimes we failed a question because we didn't look at every word and answer the question. And this particular one, pre-existing, it's not a new criteria. So if you were meeting this criteria in the past, you should be still meeting it by doing what you were doing before. So restraint elimination and use of alternative interventions should be incorporated into relevant policies. It doesn't say that everything about the next part of the question or statement should be in the restraint policy. It says into relevant policies, and it's talking about including those things that relate to procurement processes, clinical trials, and use of equipment. So thinking about your purchasing policies, your equipment and environment policies, your care planning, clinical documentation, report writing policies, they're an extension. So some of the compliance might be in those areas as opposed to just in the restraint related policy and procedure. So that was something that came up recently and was just a point of discussion, and it was clarified that there was no need for a finding, that the information was in the relevant policies and procedures. Another example, this one was also 6.2.4. This was also pre-existing. And once again, as I say, just a reminder, we're all learning. You know, we're all trying to figure out what the interpretation is, and it may vary depending on the size, the context, the levels of care, the mix, the configuration, all sorts of things may determine a slight difference in your service to how it's done down the road in another service. So this one in particular, each episode of restraint shall be documented on a restraint register. Now, the interpretation was that all of the things A, B, C, D, E, F, G, H, I should all be on the register. Now, I have had confirmation from Health Cert and from the audit agencies that they accept that that's not the case. The register is a minimal set of information. It's really giving you the resident details, what type of restraint, when it was started, when it might be next due for review. So it's giving you that first glance, that first look at things. So the rest of the information, if you look at the lettering in red there, and in people's records. So further information absolutely must be there. And some of that information relates to the reasons for initiating the restraint, the decision-making process, advocacy and consultation that was involved there, the outcome of the use of restraint or any impact, risk, thinking about trauma, and as I said before, thinking about trauma and informed planning. So if somebody has been in a trauma situation before, are you actually re-traumatizing them by what you're putting in place, or the strategy that you're determining or thinking about using? So those are the key things that I wanted to sort of raise with you today. As I say, we're all learning as more and more audits happen. There will be other things that come up. Let's keep the dialogue going. You know, we work in partnership with you. We're here to support you to make sure that you're doing the best you can within our capability. As I said before, I wish I had a whole busload of extra staff I could send you all, but unfortunately I don't. So just before we move on, I'm going to get Mark to open up his microphone and say hi. And Mark, give us a wave.
Hello.
Mark is our business partnership manager in the office here, and he is supported also by, lean over this way, Catherine. This is Catherine. Hi dear. Catherine's just recently joined us. She's our quality systems administrator, coming into policy and procedure production area and supporting you in that context. And Carolyn, we've got Carolyn hiding behind the scenes. I can't see everybody, so hopefully you can see.
Yep, she's there.
She's there. There we go. So Carolyn's on our support team there as well, doing a range of functions as we all work in together doing different things. So if you have queries for us and I'm out of the office, there may be a slight delay if you've just written to me in your email query. So I suggest if you write your queries to support@agedcarecompliance.com, then any one of us might pick up that and you'll get a very prompt response. So moving on, there are changes. Some of these have come out of the new Paerewa Health and Disability Services Standard, and some of those are terminology. As I said, enablers is a piece of terminology that doesn't appear in the standard anymore. IPC, infection prevention and control, as we used to call it, is now infection prevention and antimicrobial stewardship. We've called it IPAS for short. So we used to have document code in the top right corner of those related documents. You would have been used to seeing IPC. We've changed that. As you get your new set of documents as they come due, you will see instead that code has changed to IPAS. Also, consumer rights in the previous standard has now changed, thinking about the standards being from the consumer perspective, and the coding has changed from consumer rights from CR to OR. So our rights that relates to, just reinforcing these should be taken from the consumer perspective. So looking at HCSL, I just wanted to, before we go on to Q&A, go on to some new features. We have had some new features added recently, and some of those are here. HR module gives you the ability to note all of your staff register information, their appraisals, schedule those ahead, get automated reminders, have the competencies in there, choose from a range of competencies and have that competency tracking. We are in negotiation at the moment, and we're going through a discovery phase with some recognised education providers to look at some content that is recognised, that's hopefully mapped against NZQA, so that we can link or have an integration with that into the system as well. Once again, trying to bring everything together so it's a one-stop shop, so you don't need to be going into all sorts of places looking for things. So anything that we can do to help streamline are things that we're happy to look at. In that staff register with the new standard, once again, it requires the reporting of ethnicity, not just of residents, but of staff as well. So in the staff register, it accommodates all of those things, and visa tracking, etc., etc. One of the other changes that we've had recently go live into the system is the automated occupied bed days. Now that's evident under the system setting tab as automated. It picks up the level of care from the resident profile. It's doing it automatically. So there's nothing you have to do other than make sure that if there is a change in the level of care of a person, that you have closed off the previous level of care that you've noted for them and add the new level of care. All right, so you need to close one off before you make the change. Now, the resident movement report will note those changes. It's updating in a dynamic way. It was once a month that it was doing it before. It's now doing it on a daily basis. So you can look at that, you can put a date range and see exactly what the changes in level of care, your admissions, your discharges, and the related levels of care in the resident movement report. Now, the next piece of work that we've got undergoing at the moment that we're progressing through is the financial module. And that was asked by quite a number of our clients as well, a number of you, to align and help reconcile with your payment schedules and things like that. So hopefully these will all make life a little easier, streamline things, save you time, so that you can do more with less. All right, so have we got any questions out there? Now you can unmute your microphone and see if we've got any questions. Have we got any questions there?
Hi, Jill.
Hi.
It's Mela from Riverley and Eileen.
Hello, Mel. How are you?
Good, thank you.
Good. How can I help you?
Just a question for the enablers. So do we still have to monitor them?
So with an enabler, look at the definition in your policy,
Okay.
and see if it still comes under the restraint standard. Any strategy that you put in place that is going to restrict a person in any way from what they would normally choose to do, and these aren't quite the words that are in the policy, but have a look. This is the concept. If I am being restricted in any way, then I'm being restrained. And
Okay.
in that case, absolutely, you would be monitoring and filling out those forms. You would be noting your monitoring frequency within the care plan and making sure that the staff are complying with that monitoring frequency that they're writing in detail. So there's evidence of when the restraint went on, when it came off, how care was being provided in between those times, when there was pressure, relief, when there was movement, when there was hydration and food and distraction and de-escalation and toileting and socialization and anything else that is part of providing care, that you would note those things in the monitoring, so that that's quite evident. Does that answer your question?
No.
No.
Sorry, Jill, our enablers are for people to help move them while they're in bed, particularly. It's the classic one.
So this would be the new definition of an enabler. So an enabler we would think of as a mobility aid or a safety a safety aid. If the person is able to manage it and it's not restricting them, and that's the definer, if it's not restricting them, but it's actually enabling them and helping them, generally you don't need to do the monitoring, but I want you to do a risk assessment. Is there risk associated with that being in place? If there is, then I would suggest that you do have monitoring there. Anna, can you unmute yourself and come on in? Have you got something to add, please, to the conversation? If there's anything
I was just going to say, our understanding is, so previously it was an enabler if the person could request to have it on, and they requested to have the bed gate up, or they requested to have a table locked in front of them because they'd stopped them sliding out or whatever. whereas now it is if they can remove that themselves. So they may request to have their bed gates up because they feel safer or that helps them move, but unless they can actually put the bed gate down, then it is a restraint. That's our understanding at Cook Street. Is that
that's right, Anna, because regardless of who's asked for it, if the person is restrained in any way or they're restricted in any way and they can't manage it themselves, then it's restrained. Yep.
So it gets around that conversation we had with the auditors every time, because some would understand an enabler and some would see it as a restraint. And so it's kind of just taken that enabler conversation away, hasn't it?
It has, and hopefully it will make it easier. I'm sure there'll still be some questions and queries, and once again, we're happy to go through that on a case-by-case basis and talk about particular scenarios. We won't do that today in this sort of public forum, but if there's a particular case and you're not sure, then ask that. The standard does say if they can ask to have it removed and it will be removed, then it doesn't need to be monitored. It depends how long. This is a question that's come up in the chat. Thank you for that. It depends how long the delay is. If I have to wait to have it removed, then for that period of time, I am being restrained and I'm not able to follow through the choice that I would want to make at that time to move or go to the toilet or whatever. If I can't do what I want when I want, because of a strategy that's been put in place, then I would consider that as a restraint. Okay, so once again, something else in the chat, if a resident wants her bed rail up to have her bed remote accessible for her, is this an enabler or restraint? She can't take down the bed rail. If she can normally get out of bed or she can normally move about and it's going to restrict her in any way and she has to ask for assistance to have that taken down, then yes, that's restraint. Okay. So once again, think about freedom of movement and any restriction that's that results from a strategy being put in place, regardless, as I say, of who's asked for it. What about a lap belt that a resident can apply and take off? Would that require monitoring? Now, in that instance, no. If the person can manage it themselves, they're not being restricted, they can, maybe I'm a double amputee, for example, in that situation, it may be that the lap belt is put on place so I'm not falling out of my wheelchair. I can put the lap belt on myself, I can go down the road in my wheelchair, I can do my shopping, I can come back, I can take that lap belt off, I can put myself on my bed and have a rest. I can get up again, move myself into my chair, put the lap belt back on again. In that instance, no, it's not forming any form of restriction. As I said, if there's a hint at all that there's any risk associated with that, just always think about risk. Is there any risk? Any time that there is a strategy of any sort put in, I think it's a good thing to have in mind. So how does this standard relate to isolating residents due to COVID? In essence, their movement is being restricted, isn't it? And I think this is why the Ombudsman certainly gets involved in looking at dementia care services in particular, because people are restricted, they are detained in an area. This is where the health order came in, is my understanding, and there was pieces of legislation that enabled this to happen. So it sort of is bigger and beyond what is reflected in the standards. Okay, so I've just got more coming up in the chat line here, and I'm not sure if I've missed any. Can you speak about the elimination of restraint from a governance executive leadership level, supporting a person's choice to have a device that makes them feel safe or helps them move, but has a risk attached to it? How will we respond from an auditing perspective? Any advice? So what we want to be able to occur is that people have choice. People need to be able to make choices that are relevant to them, that are meaningful for them, that allow them to have the quality of life that maximizes health outcomes, maximizes their ability, their independence, There is mana enhancing. Think about those concepts as well. So when it comes to supporting a person, and on the one hand, they want it, and they say, look, I'm scared of falling out of bed, and each time I turn over, I want bed rails there so that I can actually sleep, because without the bed rails, I'm worried about it, I'm not getting sleep. The governance board, on the other hand, is saying, well, actually, that's showing as a restraint on our register, and it makes us look as though we haven't achieved our elimination strategy, and this makes us look not good. I get that. It's complex, and sometimes the use of something that limits might be okay because it complies with a person's right of choice. Make sure that you're consulting the family, the whānau. Think about other strategies. Could it be that you use a low bed? Is there something else that you could use that might be a different option that they haven't thought of, that they're not aware of? Think about those things. You know, consult your equipment supplier, talk to them, talk to psych services or disability support, whoever it might be that is supporting this particular resident. Think about it on an individual basis. So another question here, if that resident is unable to mobilise at all, hence it's not restricting their movement, then is it an enabler or a restraint? Now, is that the question? It just says if that resident is unable to mobilise, hence it isn't restricting their movement. So I'm figuring that you're asking, is this a restraint? If somebody can't move, then you know that immobilizing that physical result of being immobile is going to have risk for them. So potential for risk for pressure injuries is an obvious one. So think about the risk, as I said before. Are you managing the risk associated with that? I would say that whatever strategy you put in place, as long as it hasn't changed the mobility, you could argue the case. But make sure, once again, that your documentation is comprehensive and that each time you get that review process, or if there's a change in between those standard reviews, that you review early. Don't hold off just because your 6 months hasn't come up, or your 3 months, or whatever you're doing. All right. Adding further to the question, the resident is concerned is a stroke patient and can't get out of bed herself. So yeah, I think basically what I've said already covers the bulk of those things in relation to think about movement. Is it changing? Is it restricting? Is it changing choice for that person, regardless of who has put the strategy in place or who has suggested it? What else have you tried? Is this helping? Does that answer your question?
Yes, thank you.
Okay, great. Yeah, it's, you know, care is not easy, is it? Because there's no hard and fast. It's complex. There are different scenarios, different residents, and everyone has an individualized situation that we need to factor in, a whole lot of different things that we don't need to for other people. So, and I know you're all pushed for time, and sometimes just give me an answer, black and white, that would be good. Sometimes it's not that easy. As I say, if you've got a particular issue that you're concerned about, then I can certainly have a one-on-one conversation with you and talk through the particular process that you've gone through for your risk assessment and your planning and your monitoring. So as I say, we can't sort of say just generically a hard and fast yes or no always, unfortunately. Current restraint for assessment form covers cultural assessment, whānau involvement, but are there more things that will be added? At this point in time, no, not for the assessment form. The assessment form that is in place does meet the criteria in the standard. That's not a criteria that's partially new or new. All right, do think about your de-escalation, do think about your the cultural aspect, and if you've added more in there, think about equity in relation to each individual resident, and it may not be a factor at all, but think about it. It's great having these questions come through. It's nice to sort of be able to have a chance to have a conversation, even though it's a little bit one-sided. Feel free to open up your mic and have another. I'll stop sharing my screen so I can see more of you. Oh, there we go. Now I'm not sitting here alone. It feels so much better. Have we got any other questions? I think I've answered all those questions that came up in the chat so far. Just looking here. Have I missed any, Mark?
Hi,
no,
Gillian.
that's all.
Hi, Gillian. It's Cheryl from Scoville Healthcare. How are you going?
Hi, Cheryl. Good, good. Nice to
Good.
see you.
Just a complete different. While we've been listening to people's questions, we've just been looking at the automatic occupancy bed thing. Just having a look, and ours are completely wrong. So we were looking at going backwards and trying to adjust to correct them, but it won't allow us to do that because it's already in. So is there anything we can do about that, or do we just have to correct them and go, where is it getting the information from? Can you just go through that again? Sorry.
It's getting the information from the level of care and the resident profile. So each resident in the resident profile has a level of care, and the system is reading those and counting them. So it may be that the base number of residents that we have noted for you that's built into the formula in the background of the system isn't accurate. So, Mark, can you remind me after the call? I do have another Zoom coming up a little bit later, but we will come back to you and talk through each of the cases just to make sure that that's aligned and corrected for you.
Because at the moment it's so, for Weasley House it's way out. It's telling us we've got 341 people today. I'd be happy with that. But...
yeah, absolutely. So remember that it's reporting the occupied bed days per month and not the number of residents you have. So at any point,
yeah, no, I get that. It's still not
right. No, because you're
yeah, okay. And so then so it's doing that each day. Okay, I understand what you're saying.
So
yeah, but maybe we just need to have a look at it. I can email you the correct occupant, beds.
Great. The other thing that may be a possibility is that there may be residents that have had files still active that should be deactivated.
It's just no, you've done that. No, that seems to be
done
okay.
that.
Yeah.
Okay. All right.
We'll have a look. I'll just for ease, I'll send you a quick email just to let you know what our correct occupancy level, what our correct bed capacity is, and then you can just double check on it for us. Maybe it is right.
And
maybe I've got my maths wrong.
It's important that we do have the bed capacity numbers right for each site, because that affects your benchmarking for everybody as well. So please make sure that if that's not looking right, that you let us know. The system has been updated recently on the 13th of July to be more dynamic. It used to, as I said, do a monthly. At the end of each month, it would update and show you the bed numbers or the occupied bed numbers for that month. It's now doing it on a daily basis. So that, and it's automated, so that has changed the way that looks at the moment, but that will be consistent going forward, and that was something that was asked for, so it was easier to reconcile the accounts and things.
Okay, that's awesome. Thank you.
It's all right. Any other questions? It's nice to see faces all coming together, isn't it? Hopefully a number of you are going to be able to come to the NZACA RVA joint summit in August. That's in Christchurch. We're based in Christchurch, so that's easy for us. I know it's not easy for travel, and a lot of you haven't got any staff capacity to allow you to do that. But
there's a comment in the chat there. There's a good one, a long one there.
Okay. Oops, there we go. I need to scroll down. Do we need job descriptions for a restraint coordinator? Yes, it should be in one of the job descriptions. There is your restraint. In the restraint policy, it talks about restraint coordination and the functions and responsibilities for that role. So there does need to be a job description in line with that. We don't provide the job descriptions within the policies and procedures and forms and software that we provide, but we do have templates. So if you don't have one, let me know and we can send you a template that you can then tweak and modify to match what you need for yourself. What else have we got here? All seems good. Just had an audit in April, which was a success. Had no things for them that I needed to change. Excellent, that's what we like. Prior to the audit, made some changes as in Maori language for the areas such as toilet. Yeah, they are looking for that co-design, the te reo languaging or labeling, so that we've got that evident in the service and how we do things. So some of those basic labels just to help.
Whare paku, just in case you wanted to know.
Sorry?
I said whare paku toilet.
There we go, whare paku toilet, yes, exactly. Mark and I are both having te reo lessons at the moment. I think we won't be having a competition because I suspect, Mark, you might win. But
what is nurses station, Mark?
Oh, that's a good question. I'm going to have to find that one out.
I'd love you to find that out for me.
Yeah.
There we go. We'll come back to you with that one. As with the Pacific People's interviews that we will send you out shortly, I have been consulting Kaumatua in relation to the policies and procedures that we're developing. So there certainly has been involvement and consultation process in the documentation that we are supplying, and those details will be in your new updated policies and procedures. Just continuing on from that comment, the people that have had just had the audit, had a look at the new standards and made adjustments. I would say to everyone, it's not as scary as you think with the new standards and having an external audit. Very much looking at your cultural environment and what you do with this. So really, really good comment. Thank you for popping that in there for us to share. Does deactivating a resident to access information then impact the occupancy levels? So deactivating a resident file means that that resident is no longer there, or they may be on, if they're on social leave or in hospital on the days that are allocated or allowed within the ARC funding contract, then you can put temporary absences in the edit profile under resident details. So you still leave, in that instance, you would still leave the file active, but you would note that they're on social leave, the date that it started, the date that it finished, and the system will track those for you as well. The person here, I can't see your full name. Somebody has asked for templates of the job descriptions. So if you can just send an email to support@agedcarecompliance.com and request those, absolutely, we'd be happy to send those through.
Gillian, is that a general job description template or an outline for a job description for the restraint coordinator?
I've got a whole series of different job descriptions for all sorts of different roles. Would we get an email regarding summit in August? That would come through if you're a member of the NZACA or the RVA, that will come through to you automatically. You should have been receiving emails from them if you're a member. If you're not a member, then I strongly suggest considering becoming a member. It really is of good value, and they are the lobbying group for aged care services. They're working so hard to try and get extra funding and extra support for the sector. So I really do suggest that you consider that if you're not. If you are a member and you're not getting those emails that come via In Touch every Friday, usually early Friday afternoon, then do contact the NZACA office in Wellington and ask them to add you to that database. Here we go. Nursing station. Here we go, Anna. The answer has come through, one of our trusty friends, colleagues here. And the answer is Te Hana Tapuni. T-E-I-H-A-N-A, one word. Te Hana Tapuni. T-A-P-U-N-I. There we go. That's nurses station for everybody. Today's lesson.
And we've got treatment room too. Whoever
Treatment
Eddie's
room.
is, thank
Yeah.
you very much.
There we go. Ruma Roanga is medication room. We do not have a treatment room.
Okay.
Nice. Okay, fantastic. And I see people are having to depart when I think I've gone through all the questions that have come up. Thank you for the sharing. It's always lovely to get together and have an opportunity just to have a wee catch up and help you where we can. If we can make your lives easier in any way that's feasible for us to do so, please let us know. We're open to suggestions. We haven't got a magic wand and we haven't got a magic bank account, unfortunately, but we'll do what we can. So I don't think there's anything else. Lots of thanks. Our pleasure. So once again, support@agedcarecompliance.com. And if you've got any questions that come to mind afterwards, please don't hesitate and one of us will respond to you. All right.
Thank you everyone for joining. Thank you. It's good to see you all again, or ones I can see.
So there we go. If there's nothing else there, we'll leave you to.
Thank you, Gillian. It was lovely. Thank you very much.
Thank you, everyone.
Pleasure. Take care, everybody.
Thank you.
I'll just stop the recording.